What happens when we stop judging cosmetic surgery and start listening to the stories behind it? Whether it's about feeling good in your skin, recovering after cancer, or finally easing chronic pain, breast plastic surgery has evolved into something far more meaningful, especially in my family. I'm Dr. Jay Rutland, and today on the Health Exchange, I'm joined by Dr. Josh Waltzman to break down the truth about implants, reductions, and reconstructions and the powerful reasons people choose to make a change. This is a conversation about empowerment, not perfection. Let's get into it. Josh,
Hi.
do you mind if I call you that? Or you want to be Dr.
Absolutely.
Waltzman?
Josh, look good.
Okay, nice to meet you. What led you to plastic surgery? Where did you train? Where did you go to school? Give me the story.
Yeah, so I am Southern California, born and bred. Grew up in Orange County, and I went to USC for undergrad. And when I started college, I did not think I was going to become a plastic surgeon, much less even a doctor.
Yeah.
In fact, I wanted to be in the music industry. That's where I thought I was going to find myself. It's a hobby now. I love music, but it's not my profession. And so I actually started college and my training wanting to, like I said, be in the music industry. I wanted to work on the production side. And that's how I started. And it wasn't until the end of my freshman year in college, I took a class, like a kind of a general education class in science. And that really just opened my eyes to what medicine and health and all these things were at a much higher level than in high school. And that kind of changed my trajectory from that point forward. It sounds kind of crazy to say that one class did that, but that's the truth. And so I was studying business and I enjoyed that at the time. And so I continued to study business at USC, but I did all the requirements to go to medical school. And that's kind of my path to medicine, if you will.
Nice. Where did you train in Southern California too, or did you do med school in Southern California too? Stay here for everything?
So I went from LA, went right down the 405 freeway to UC Irvine for medical school.
Nice.
While I was in medical school, I also decided to do their dual degree MD MBA program.
Very
And so I continued my business education formally at the same time as medical school. And so it was a fantastic opportunity and just a knockout program that they have at UC Irvine for that. After medical school, then I packed up my bags and I went to the East Coast. So I trained in plastic surgery at the University of Rochester in upstate New York. And then after completing that residency, I did a aesthetic surgery fellowship at the Cleveland Clinic in Ohio.
Nice. When you were in medical school, did you decide early on you wanted to be a plastic surgeon? When did you say, you know what, I'm doing this?
It was not right away. When I started medical school, I felt like I wanted to do something hands-on. I like that. Being a musician, I was hands-on. I was creative with my hands through piano and clarinet and all the other instruments that I enjoyed. So I knew I wanted to be hands-on with something, which to me meant more procedures, more surgical. But I didn't know what that meant. As you well know, none of us know what that means when we start medical school.
Right.
And so I knew it was something surgery, but didn't know what. It wasn't really until the end of my second year of med school where we start to get the opportunities to do some shadowing experiences with practicing physicians that I got exposed to plastic surgery. And I was fortunate enough at the time to be paired up with the chief of plastic surgery at UC Irvine, and that was just kind of fortuitous. And so I spent a couple weeks shadowing him one afternoon a week, and that just opened my eyes to plastic surgery. And I was like, this is where it's at. And it was really the breadth of what the field and the specialty offers, from cancer reconstruction to elective surgeries to traumas to burns to pediatrics. I was like, this is like head to toe everything, and every patient in every room that we're seeing has a completely different story. So, and I saw how happy patients were, the positive difference that they were making in the lives of patients. And from that point forward, at the end of my second year, I was like, this is it. I found it. So I was fortunate to have that experience.
What was that patient story that year that really led you to be like, you know what, I'm doing that?
I think it was the whole gestalt, the whole combo of everything. I can still remember back that we were seeing patients that had breast cancer and they had taken pieces of the patient's abdomen and transplanted it to their breasts, and my mind was blown. I didn't even know this was a possible thing. And then going to another room, another patient stands out that actually this is like a freak accident thing. She had a spoon that she put in her garbage disposal by accident, and the spoon shot out and fractured her face. I mean, this is like a total freak accident type thing, but just seeing that difference of these are such a broad area of treatments that can be offered in plastic surgery, and the same surgeons treating both of these things at the same time in one day.
The other thing I found interesting about your story, and you can go into it a little bit, is you decided to continue to focus on business,
Yes.
getting your MBA. Why did you do that? Was there experience you had? Did your friend say something to you? Like, what was that?
So I know that's not the path most traveled. And typically people that get a MBA have worked for a couple years in industry and then go back and get it for a variety of reasons. I really enjoyed the business education that I got in undergrad, and I really found it interesting. And I had kind of an inkling that at some point I might go back in my career and maybe get an MBA if the opportunity presented itself, if I was getting more into administration or whatnot. It ended up being a fantastic additional year of schooling because I wouldn't trade it for anything.
Yeah.
It was such practical knowledge, and at the time, I didn't really know exactly how I was gonna use it because that was before residency, before life, before kids and everything. But now looking back, it was a fantastic education because I opened my own practice after fellowship. All those tools and all that stuff, I kinda dusted off those cobwebs, 6, 7 years later, and I was like, "Okay, I can kinda hit the ground running a little bit better than if I didn't have any formal business education."
So you went from fellowship directly into opening your own practice.
I hung my own shingle day one. I had 0 patience. I had a lot of sleepless nights and probably contributed to some of the gray hair that I have now, but, yeah, that's how I started out, was just literally opening my own practice after fellowship.
Was there ever a point early on where you're like, this isn't going to work? I'm so scared. I can't believe this.
Definitely. I mean, you're seeing a huge investment when you don't really have much to your name at that point, and you see money going out, and you're just kind of building this whole this infrastructure that you hope is going to work, and fingers crossed. I just kept telling myself like, if you're a good person, you do the right thing, the rest will follow. Like, and I still stand by that to this day. I mean, that's how I kind of practice. Treat the patients the right way. Don't sacrifice. Don't cut corners. And do a good job and be a nice person and be available. And things will happen. And it did. But it took a lot of legwork in the beginning. It still does. But it was a lot of just getting myself out there and making myself available to people.
Your philosophy and approach to the patient is, what do you want people to know about that?
I mean, my approach is always to focus on the patient's goals.
Mhm.
I think there's a lot of surgeons out there who will find what's wrong with the patient and point out a lot of things to them, but I try not to. I mean, I really let patients drive that conversation and really focus on what bothers them. Now, of course, if they're missing something and I feel like you have to do this in order to achieve this, then I'm going to step in and say so. But otherwise, if say we're talking about the face and someone's eyes don't really bother them at all and they're there for their neck, I don't really like to bring up their eyes. It's just not my style because it's not really what their focus is or what their main concern is. Unless I feel like it's going to somehow hinder or hamper their results in the end, then I'll step in. But it's really about making them more confident and feeling better about themselves. The majority of what I do now is elective surgery.
Right.
So it doesn't have to happen. And I'm very clear with patients about that this is your choice. It's not medically indicated for the most part. And so it's really about making them feel better about who they are and present a more confident version of themselves.
You focus on breast augmentation. Is that right?
We do quite a bit of that. Yeah, I'd
Yeah.
say about probably a half to maybe a little more than maybe almost 2/3 of my practice is breast related.
Why the breast? Is it that's what patients kind of picked, or is that something that you wanted to focus on?
I think all the above. I think breast surgery in general always ranks very high when you look at all of those, like these national data sets of what people are doing each year. Breast surgery is always up at the top. It has been consistently. So just statistically speaking, I'm going to see a lot of breast patients. I also really enjoy it, and I think I'm pretty good at it.
Yeah.
Not to toot my own horn, but I think I do a pretty good job. And I think a lot of my experience with breast reconstruction really lent well to transitioning to doing a lot more elective cases, revision cases, more difficult cases that other surgeons may not want to take on. I felt more comfortable with that kind of full recon background.
And reconstruction background, is that secondary to breast cancers and things like that?
Yes, definitely. So through training, we did a lot of reconstruction. That's the bread and butter of plastic surgery training, is mostly reconstructive plastic surgery, which is one of the reasons I wanted to do an aesthetic fellowship, was to kind of round out and really hone my skills in that particular area. But I did quite a bit of breast reconstruction in the first half of my career so far.
Is there a particular breast case that you kind of think in your head, like, damn, I did an awesome job on that, or I'm so glad I helped this lady out? Like, is there or like you finish and you're like, man, those look great. Like, is there something that stands
For
out?
sure. I mean, there are definitely those standout patients where you've been through, in the case of cancer, it's a journey. it was like it's a year-long journey for, I think, any woman who's gonna go through the reconstructive process. You just kinda have to take a year of your life and kinda devote it to reconstruction in some form. And so, yeah, there's definitely those standouts where you've been through thick and thin with them, and then in the end of the day, they're super happy, you're super happy, and you feel really good about it. You know, cosmetically, they look better, no one's gonna deny that, but they feel whole. And there's something that you can't really quantify that for a woman when they're going through this process, just that the psychological aspect and the impact that that has.
I want to hear a specific story. I'm going to tell you one of my specific stories. So my wife had stage 1 breast cancer and she was 36 years old. This was maybe like 3, 4 years ago. And getting that diagnosis for a 36-year-old female is awful,
Yeah,
right? And I
totally.
had to give it to her after I'd looked up the results when we got the biopsy done. Either way, this was like a year-long process of reconstruction because you have the double mastectomy because she was, she wanted to make the decision of, I just want them out. I don't
Right,
have to worry about it, whatever, which is fine. Like, you don't think about kind of the consequences of that, but it's fine. But you do that, right? And so what we did was we did the double mastectomy. And then our plastic surgeon at that time said, okay, we're going to put some spacers in and we'll expand the spacers.
yep,
We'll do this over the course of time. So we made it like a 2-part surgery,
right,
right? So put the spacers in. And so this is just when you have, I don't even know what you call it, mesh or whatever it is that you put it in there and you fill
mhm,
it up with water and you pump it up or whatever. You stretch out the skin to get the chest ready for, the breast size that you want, I guess.
right,
But it's a pretty dramatic process
it is,
for a woman to go through. And I just remember this with my wife and my wife just being worried about what she was wearing, what she couldn't wear.
right,
And then it was time, and this was like April, and it was time for like the augmentation and the implant. And she's nervous and she gets the augmentation and she's nervous because I'm about to turn 40 and we had planned this big party in Vegas. And so she, had rented out the cabanas, all this stuff, right, to go have fun. And she was worried about her body.
yeah,
So she goes, she has the augmentation, and she comes out of it and she looks. And I remember her. She came downstairs. I'm in my garage. My garage is the gym. So I'm lifting in the garage. She comes outside and she puts her bathing suit on that she's going to wear. And she's like, what do you think? I
yeah,
saw the amount of confidence
right,
that was infused. And
100%.
you have to experience that all the time. So is there a story that stands out to you?
Sometimes it's the younger patients,
Mhm.
and such as your wife was definitely on the younger end, that are in that during that specific time period of their life when, not that it's not impactful at any period of time, but for the younger patients, I think there's even more of an impact to losing your breasts through surgery. But I mean, it's rewarding for me as a surgeon. I know it's rewarding for them as a patient.
And you said earlier, you said, I think I'm good at it. What makes you good at it?
Other than just doing it a lot, I mean, there's something to be said for, like, the
Mhm.
the Malcolm Gladwell 10,000 hours, right? I think it's a lot of 3D spatial relations. I think being able to visualize things in 3 dimensions really helps, and for whatever reason, I think I've developed that skill really well, and so as you're operating on a breast, it's not a flat structure, it has a shape to it that's irregular in certain areas, it's convex, it's concave, and there's certain areas that should be fuller than others, and I think being able to visualize that before it happens and kind of see what you want in the future, I think that kind of really has helped.
And you've got breast augmentation, breast lift, mastopexy, I guess,
Mhm.
and breast reduction. Tell me about those cases, the differences, what those things actually are.
So, in general terms, you can make them bigger, smaller, or higher.
Okay.
That's
Don't be
that's
shy.
that's the easiest way to
Right.
break it down. Nobody wants them lower yet. No one
Okay.
has come and asked for lower breasts.
Oh,
But bigger, smaller, or higher is what we get. And so a breast augmentation is a very common term, breast enhancement surgery, and that literally makes patients a bigger version of who they are. That is the simplest way to think about it. It takes you and makes you a bigger, augmented, or enhanced version of you. Then you have mastopexy or breast lift, which is really a lifting procedure only. A breast lift brings the nipple position up and it removes excess skin, but it does not change the volume of the breast at all.
how do you lift it? How do you lift the breast? Like I know how to put I've seen an implant get put in, but like when you're lifting it, like what are you doing? What are you attaching it to? Like
So it's most of the time there's different techniques, but in broad terms, you're essentially removing excess skin from the lower portion of the breast
Mm.
and then elevating the nipple position. And we have to basically lift up the skin of the breast, or the medical term would be like degloving, basically, or raising a flap, and then shifting the whole breast up higher on the chest, and then wrapping that skin around it again in a higher position on the chest. It's kind of wild to watch one because going through the process in the OR, if you haven't done a whole bunch of them and seeing it, you look at it and you're like, this is like a jigsaw puzzle. Like, how is this ever coming back together?
it sounds like it,
And
yeah.
then it does.
Yeah.
And then it does in the end. But so a breast lift is to lift the position of the breast higher on the chest and remove loose or excess skin. And then a reduction is just what it sounds like. So you're taking away excess tissue. Usually, most all the time, a reduction incorporates a lift, but a lift does not have to incorporate a reduction.
Got it. Because I feel like if you're doing a reduction, you take away I guess, the adipose, the extra
Yes.
adipose tissue that's in there. I feel like the skin is used to more tissue, and so it's gonna sag.
Right.
And
So
so
you got to
that's why
lift.
you gotta
Yeah,
lift it.
exactly.
Now, do you actually cut around the areola and the nipple and move it up yourself, or do you, or is it the
Yes.
skin that you do?
Yes. So one of the most common misperceptions about breast lift and reduction surgery is that patients think we actually remove the nipple and the areola from the breast.
Yeah.
That is totally false.
Okay.
The nipple stays attached to the breast the entire time. And what I explain to patients is we have to maintain blood supply. If that nipple is going to stay alive in the areola, we have to maintain blood supply somehow. So it very much stays attached to the underlying tissues and the breast tissue. And then everything around it is removed and it slides up higher. And then everything, like I said, is kind of wrapped around and the excess is then trimmed.
So can a genetically born female, if she has a breast lift,
Mhm.
can she still breastfeed?
Yes. So I tell every patient that there's no reason you can't attempt to breastfeed. What I do tell any patient that's going to ever consider having breast surgery, whether it's an augmentation, a lift, a reduction, is that the chance that you might have to supplement with formula goes up a little bit. And that's just kind of, I think, a good disclaimer that any plastic surgeon should be telling breast patients. Because anytime you're making an incision on the breast, you are creating scar tissue to some degree, right? And some of that scar tissue might affect some of the milk ducts. And so I tell patients, yeah, you can go ahead and try to breastfeed. You might be completely successful. And I have a lot of patients that have been successful,
Mm.
but you might have to supplement a little bit with formula. Now, the flip side of that is that there's millions of women that have never had breast surgery at all. They have no scars on their breast and they need formula.
Yeah. Right.
So, in breast size does not correlate to ability to breastfeed. We know
Right.
that. So I tell them they can totally do it. They might have to supplement. They might be completely successful, but that's kind of my disclaimer.
When you're doing these surgeries, the motivation for doing the breast surgery, at least hearing you, was at least at first it was kind of when you were training, it was reconstruction,
Right.
and now it's shifted to more of a confidence builder. Just talk about like your motivations for the surgeries, and are you doing gender affirmation surgeries as well?
Yeah, so there's a couple questions rolled into that one.
Yeah.
So motivations for patients who are looking for more elective surgery, I guess, is the first kind of topic. So it's a confidence booster for most patients. For a lot of breast augmentation patients, it's that they never develop the breasts that they were hoping to when they're going through puberty. It could be to fit better into clothing. It could be correcting an asymmetry that one breast developed more than the other, and they need to balance some things out. And we can use different size implants for that. That's most of the augmentation population. Then motivation for patients. Then there's the next group of patients that have had some children, they've been through life, and the breasts might be a little bit lower on their chest. They might be lacking a little bit of volume on top from breastfeeding now. And those patients often come in for some implants with a lift that they're looking to kind of restore that pre-baby body, if you will. And they want the breast back up where they used to be before breastfeeding, and they want to remove the loose skin, and they want to fill out what we call the upper pole or the upper half of the breast that's now very sunken or concave. And so that's where the implant helps to kind of round things out, and then the lift helps to get the nipple back in the right position. So that's that population, and that's about restoring what they once had, and maybe even enhancing.
Yeah.
Maybe they never quite had what they were hoping for, and this is a chance to now achieve that. And then the breast reduction population is women who have been plagued by large pendulous breasts most of their life. They have shoulder pain. They have grooves from their bra strap. They have rashes or irritation under their breast folds from sweat and rubbing of the skin and chafing. So they come in with a whole different set of motivations for breast reduction surgery. The question about the gender affirmation, yeah, that it's not the majority of what I do,
Mhm.
but several times a year, I definitely have patients, both male to female, female to male, for chest masculinization surgery or for breast augmentation. And that does come up time to time, and we do that as well.
How do you decide on the implant? Is it cost? Is it
That's a huge topic within plastic surgery of implants. So the are you saying in terms of material, what's the difference, or how we go about making that
decision?
decision process
Decision
with the
and
patient?
material, sure.
So the two camps of or flavors, as I say in the office, of breast implants are silicone and saline. Saline breast implants are filled with salt water, saline, and silicone implants are filled with the silicone gel. Each implant has a silicone shell. So either way, no matter what patients choose, the part that's actually in contact with their body technically is silicone. And so when people say, I don't want any silicone on my body, well, what they're really saying is the filling. That's what they're picking. Saline technology has not really changed much over the last number of decades. It's still basically a bag that we fill with saline. And then silicone technology has continued to evolve multiple times to where now we're on our 6th generation of silicone gel, which is an extremely different product than it was before the year 2000. In the 90s especially. Very, very different product in terms of efficacy, technology. They're not comparable. In my practice, probably about 98, 99% of patients are choosing silicone. Once or twice a year, I might do a saline breast augmentation or a revision with saline implants. And it's really now for patients who have experienced saline before, they've been happy with it, there's no reason to change, they don't want to rock the boat, so great, let's use saline. Or for a patient who everyone they know has saline, their mom has saline, their aunt has saline, their best friend has saline, and they just want to get saline. Fine, let's do it. You're going to have a great result. But for the vast majority of patients, I think silicone does respond a little more like natural tissue. It's going to move better with the body. It's going to have less visible rippling and just be a higher performing implant, meaning that it's much more difficult to tell now where the breast ends and the implant begins and vice versa.
Yeah.
Versus on a saline implant, it is a little more palpable sometimes where you can feel, oh yeah, this is actually the implant because I can feel it and this is the breast tissue. Silicone technology now is so far advanced that it's almost imperceptible in some patients where the implant begins.
What am I hearing about round versus teardrop? Are these like different?
Yes. So
Was it my hands? Are my hands in the right spot?
this is how we define round and teardrop now.
Right. This is it right here, right?
This is it.
Okay.
That's the universal sign for implant.
Right.
So round versus teardrop or anatomic is the other term we use for it. Round implants are the most common. That was the first type that was developed, and there's no top and no bottom. So essentially, you could spin it around 180, and it's going to look and feel the same because it's just round. It's no top and no bottom.
Okay.
And they do actually spin quite often in vivo in the body. They are constantly kind of rotating just because they're not secured in like with suture. They're just free floating in there, but you don't notice because there's no top and bottom. With a anatomic or a teardropped implant, there's definitely a top and a bottom, so it's more tapered on the top and fuller on the bottom. It's great as long as it stays oriented in that fashion. Okay, but if they rotate, or if they rotate 180, you're going to have an upside down breast on your chest, which is not attractive or desirable for most women. And so that usually needs to be fixed with surgery.
So what do you put in, round or teardrop, or do you just
Now,
give them a choice?
I would say most in the US now, the pendulum has swung almost entirely back towards round implants.
Got it.
Anatomic implants also have what's called a textured surface. Not quite as rough as Velcro, but it needs to be textured so that when you put it in there, it is much more secure in that pocket and kind of like almost adheres to the tissues like Velcro to minimize that risk of rotation. And so that's a necessity for any anatomic or teardrop implant, is that it has to be textured. Otherwise, it will certainly spin around by the time they get home. The issue has been that with anatomic implants that are textured, and all textured implants, there is something called ALCL, anaplastic large cell lymphoma, that has found an association with textured implants. And so some manufacturers' implants have been pulled off the market completely because of the association with that, and other manufacturers still have theirs on the market, but it has certainly fallen out of favor, with the exception of patients who absolutely need to have an anatomic implant. And that has become now like the reconstruction population, the breast recon population, or women that have next to no breast tissue and they want a very, very tapered, very natural appearing breast. Those I think are also candidates for potentially anatomic implants. Otherwise, round implants look and perform just as well for 99.99% of patients.
Anatomic implants
Yes.
are textured implants?
Yes.
So, and when you say textured implants, they have a texture on top? Like that?
You can actually feel it. It feels much more rough.
And so does the roughness of the textured implant create like a little bit of inflammation and scarring so it doesn't move? Is that the whole point?
It does create, yes, there is a little bit more of that. And so you get a little more tissue ingrowth and it helps stabilize it. Yeah.
For just the audience, like when you think about the body in general, the immune system does have a job to do. It's supposed to survey the field, make sure that antigens are supposed to be there or not supposed to be there. And what the field has developed over the course of time is this shell that kind of protects your implant from your immune system. And if that shell is broken at all, your immune system can see these molecules. And what they do is they can generate B cells, T cells. They're going to generate antibodies and antigens or cell receptors that are going to try to attack proteins that look like that gel,
Correct.
and it might end up that your bone looks like it, or your foot looks like it, or your skin looks like it. And that's how autoimmune disease is thought to maybe start.
Right.
And so again, lymphoma is really just a differentiation of a certain type of white blood cell that proliferates and leads to cancer. I mean, leads
Right.
to a significant, yeah. So I can see that. And as you know, obviously in my practice, I get a lot of these types of patients that are either fearful of developing autoimmune disease, or they are usually it's like a 47-year-old female who's had breast implants for like 6 years,
Yeah.
and she now all of a sudden has scleroderma, right?
Right.
That's what I see like most of the time. It's that patient. And I look and I get the CT and I do see breast implants and I do see a suggestion of rupture. And in that case, I'm like, just get them out. And
Yeah.
I can tell you that in some of those patients, I am just like, whoa, we took out the implant and they are like
It
almost,
helps.
yeah,
Right. Yeah.
they're
So
cured. Yeah.
breast implant associated illness is the topic that you're
Mm-hmm.
alluding to here,
Mm-hmm.
for the audience, and it is a big topic. I don't advertise myself as a breast implant illness
Mm-hmm.
expert, and that's certainly not the focus of my practice. But I see a handful of patients every year
Yeah.
who come in with symptoms, and it's worthwhile talking about because it is out there in the media. And I think the worst thing that can be done by plastic surgeons or any medical professional is to create fear and hysteria for patients. I think that is so counterproductive and undermines us as a specialty because it just shouldn't be advertised that way or promoted in that fashion. So that's my PSA on that. But it's a thing. Like I'll say it as that. And so I see a handful of women each year who come in and they've oftentimes bounced around different specialists, and they end up in my office saying, I have these symptoms of X, Y, and Z, and we've been down these paths and nothing has really turned up. And I've had implants for a number of years, and I think I'd like to have my implants removed. Now, I'm just giving you my own approach to this. I will never get in a woman's way to do this.
Yeah.
So if they want their implants out, great. Let's take them out next week. But I tell everyone, like, look, this is a little bit of a black box as far as this is an evolving area of medicine right now as far as what breast implants contribute, if at all, to any type of autoimmune disease. I tell them that I'll take them out. I have patients where I've taken them out and some of their symptoms have improved, like
Yeah.
you've attested to. And I've had patients where I've taken them out and they are exactly the same as they were before surgery. They're frustrated, I'm frustrated,
Yeah.
but I tell them beforehand, this is the expectation of taking out your implants. Now, of course, the ones that you hear about in the media are the people who have a soapbox and a voice, and they had a good result. Like some of their symptoms did improve afterwards, and can you correlate it to the breast implants? Perhaps, but that gets a lot of attention.
Yeah, I mean, I think medicine's gray, right? It's not black and white. Again, for me, disease is your immune system's response to the environment, whatever it is, whether it's an antigen that you're inhaling, whether it's an antigen that has been implanted, whether it's a breast implant or a metal rod or whatever the case may
Right.
be, right? And so you just have to take all these things into account, but it doesn't also have to be that. Autoimmune disease, a lot of times, is just genetic. Hey, listen, you have
Correct.
this genetic propensity. Like your father had rheumatoid arthritis, your mom had scleroderma. Like this isn't surprising.
And we look at the population of women that usually presents with these symptoms, middle-aged women,
Mhm.
who also happen to be one of the highest demographics for onset of autoimmune.
Correct.
And so it's another confounding factor. And I never dispute or refute anyone's symptoms. I acknowledge that they have these symptoms. They're real oftentimes,
Yes.
but I just can't promise they're related to the implant. But there is that small subset that has these immune response to it, just as what they would with any type of foreign material placed inside their body.
Now it's time for What's the Buzz, presented by BuzzRx. Every week, I answer a health-related question from one of our viewers. This week's question: Dr. Rutland, I just had breast augmentation surgery, but over the last several days, I've developed some redness around where the surgeon placed my implant. What do I do now? This is a great question. The first thing I would do is make sure that your surgeon knows about the redness where the implant was placed. This could be a sign of cellulitis or the beginning of an infection. There could be a possibility that you need oral antibiotics to calm down the presence of that bacteria, which will calm down the inflammation that led to that redness. So just make sure that your physician knows. Your primary care provider can help as well. That's the buzz. If you have a question, email us at healthexchangepodcast@gmail.com. Thanks again to BuzzRx. Look up your medications on buzzrx.com or the app to see how much you can save. I've been reading a lot lately about breast reductions and them increasing lately. Why do you think that is?
I think the trend over the last 5, 10 years has been definitely a more natural shift, and I'm happy about it personally. I mean, my own personal aesthetic, I think it's great. We have the saying as plastic surgeons is big implants equal big problems.
Yeah.
It's just a gravity thing.
Yeah.
I mean, you can't defy gravity. So I think the trend, especially in Southern California over the last 5, 10 years has been towards a more natural, more athletic, more natural look, which is wonderful. It makes our job better and easier as surgeons, especially for the long-term outcomes. Breast reduction in itself is a very high patient satisfaction surgery. I think more than almost any other procedure that I do. Breast reduction patients are just like doing cartwheels when they come to see you for follow-up because you fix so many of the issues that they have almost instantly. But I think smaller, more natural, more athletic looking breasts are definitely more on trend now than they were maybe 20 years ago.
Tell me about fat transfer implants, and does it work? Is it effective? Do people get the same result? Tell me about that.
Fat transfer is a nice complement to breast surgery. So fat transfer we can do all over the body. It's not just for breasts. We can do fat transfer to the face, the breast, the abdomen, the buttock. And so it's a very diverse tool that we have in our toolbox. What it involves is liposuctioning, harvesting fat from one area of the body and transplanting it to the other. And from a scientific standpoint, you're transplanting those fat cells and then relying on the body's own blood supply to grow into that and give those new cells life and make them be permanent. That's how it works. Breast augmentation with fat transfer is a thing. I think it's really probably overblown a little bit in the media and on social media because some of the results I don't think they might be very early results or camera angles or trickery and other sorts, but it's definitely used a lot. And I say it's a nice complement. So fat grafting to the breast or transfer can be used to help camouflage an implant, for example. So if someone's very, very thin or they have some rippling because on the lower part they don't have a lot of tissue, we can layer fat between the skin and the implant to help create a thicker kind of buffer, if you will, to then limit that rippling or to help increase a little bit of medial cleavage. That's a great use for fat. In the breast reconstruction population, we use it all the time.
Yeah.
I mean, it's much more useful there because there really is no more breast tissue. Most of those patients, their breast is skin and then an implant. And so using fat to help thicken up that tissue is really, really helpful. To do a complete breast augmentation with fat transfer is another thing. And I think it's about proper expectations. So in an ideal world, I think patients can achieve maybe a full cup size with a fat transfer breast
So
augmentation
then go from A to a B. Maybe
in a good case scenario.
in a good case.
Yeah. So there's a couple things at play there. So the fat has to be able to, quote, breathe.
Yeah.
If you just cram as much fat as you can inside of this pocket that only has a certain capacity, the breast tissue, right? That fat's going to basically be suffocated. It's never going to be able to get good blood supply. It's basically just going to a good majority will necrose and die and just be reabsorbed by the body. So you have limits to how much fat you can inject at one time.
Now you mentioned liposuction.
Mhm.
Liposuction is just tell us what liposuction.
Liposuction is removing fat cells with vacuum suction.
Does it work?
It absolutely works with the caveat that people maintain a stable weight after surgery.
A lot of rappers now are getting like liposuction and contouring of their six pack
Sure.
around in their belt. So that works, is what you're telling me. Like
It
yeah, you've
does.
seen it.
Yeah, that's called abdominal etching. So you're instead of just liposuctioning the subcutaneous fat in order to do what you're talking about, they're actually taking the liposuction cannula and going right under the dermis. And so you're stripping the tissue of almost all of the fat in those areas and then allowing the dermis or the deeper layers of the skin to essentially scar down to the fascia, to the muscle. And that's how you're getting that type of definition.
What's the consequences of that?
Looking like someone took a barbecue grill and like stamped it on your abdomen.
I guess sometimes that's cool, I guess. How much does that cost somebody? If somebody came to you and said, "Hey, I want to look like Drake,"
Yeah, I mean, I don't
you don't do that.
I don't do abdominal etching to that extreme,
Yeah.
because it's just not my aesthetic.
You'll
I
do
think
liposuction.
yes,
but
I
you-
do lipo, I'll do contouring, I'll create nice shadowing, we can accentuate some of the what we call the linea semilunaris or the linea alba in the center, and that gives really nice athletic soft contouring, but I don't think, and again, this is personal, I don't think that hard etched look for a dude looks that great because when you touch it, it's not muscle,
Right.
it's fat.
And within your practice, do you have your own surgical center associated
I
with
do.
it? Okay. So
I do. I'm fortunate now. Yeah. So I moved to my current facility about 2.5 years ago, and we have a full team of anesthesiologists, and it's
just for you, or do you just hire anesthesiologists as you need them?
I work
They
with a
come-
group.
How does it go from nothing in the beginning to where you are today, to actually like look back and be like, man, I did that shit.
It's a lot of work. This is not the path for everyone, I can tell you that. It can be frustrating at times, and you're like, "Why did I do this to myself?" at times, but then you have those days where it all kinda clicks, and you're like, "That's why I did it." I went to Kinko's and printed a folder with my logo, and I put, like, all the procedures that I wanted to do and the insurances that I took at the time, and I just started calling up internists and OBGYNs and dermatologists and anyone in town, and I would just try to go over to their office, bring some donuts, sit down with them for 5 minutes, keep the staff happy, keep the doctor happy, and just introduce myself and say, "Hey, send me a patient, let just try me out." And it was just about making those experiences early on, like 5 star, and then a lot of advertising just to get the word out. I still continue. I still continue to do paid advertising. I think you have to in this day and age just to remain competitive. So it's a constant battle of figuring out what's working, what's not, going back to the drawing board and saying, "Okay, well, that campaign didn't have any ROI. Let's scratch that. We tried that. Move on to the next idea." It's a constant.
Constant. You got to
Yeah.
constantly evolve
Yeah.
in landscape, but that's okay. That's what makes it fun. When you are doing liposuction, is there any utility in taking some of those fat cells and putting it in the face where certain people might want it if they have, if they got some facial atrophy or if they have some wrinkles? Or I mean, does that
Totally.
work?
It totally works. It's a great option. About a third of my practice is face. And so I would say with facelifts, over 90% of facelifts that I do easily involves some aspect of fat transfer. Oftentimes it's to the mid face where a lot of people start to lose some volume in their cheeks as they age.
Yeah.
So even with lifting the cheeks, it doesn't always restore the volume that you need. So you have to do a little bit of fat. The temples is another popular spot. People get a little temporal hollowing. It softens that really well. The nasolabial folds are always helped by a little fat. Sometimes the what we call the prejowl sulcus, or that little indent on the sides of the chin, benefits from a little volume inflation with just a little bit of fat. But I think the key is to do a little bit in a lot of areas, not to do a ton just in the cheeks. Otherwise, you look like a chipmunk.
That seems that seems like an outpatient or in office procedure that you could do.
It can be. Yes, fat transfer alone can be done under local anesthetic alone. Oftentimes, it's combined with a larger procedure. And so it just complements at that time to do it, but it's almost hand in hand. We're not just lifting for a facelift anymore, we're lifting and filling because we know more about aging and anatomy now.
What's the most common procedure that you do besides breast? What's the most common procedure that you do in your practice?
After breast, it's gonna be some type of, mommy makeover combo, so that involves with something with tummy.
Yeah.
So a body procedure. Yeah, about 2/3 of that is breast body, and then a third of that is face, which I really enjoy doing as well. I know this topic hasn't been too face focused, but I do a lot of face surgery as well. But yeah, a lot of tummy tucks. And
What is a tummy tuck? I swear I've been saying it for years. I swear to God, I don't
it
know what
sounds
it is.
fancy,
It
right?
sounds super fancy.
Yeah.
What is it? What do you do? Like when you're operating, do you just like take it, cut out the skin and like throw it like how does that work?
It's a wild procedure to describe to someone because you're literally lifting up, popping the hood, if you will, all from the lower abdomen, like the pubic region, all the way up to the breastbone, and lifting all the skin and all the subcutaneous tissues all the way up to the middle of the chest. And then you're taking out the laxity at the end of the procedure. But the real power of the tummy tuck is the tightening of the rectus muscles. So with age, with childbearing years, being pregnant, patients that have maybe lost a lot of weight, those rectus muscles, the six pack muscles, are very much splayed apart. So they should be running vertically, pretty
Yeah.
much. But with pregnancy and being overweight and whatnot, those muscles get spread, and we call it a diastasis. The medical term is diastasis
Yeah.
recti. So those muscles are splayed apart. There's a lot of laxity in the abdomen. When patients flex, they can get like outpouching sometimes, even when it's really severe. They're not able to really engage their core. They have trouble working out. They can't do crunches effectively. So one of the real powerful moves of a tummy tuck is that while I'm in there, I can go in and physically plicate those muscles, meaning sew them back together so they're realigned back in the midline. That's, I think, the real bang for your buck. I mean, yes, it's nice to remove all the extra tissues, but just realigning those muscles so they're actually pulling in the right direction again in their normal vector, patients are able to engage their core better. They can hold yoga poses they weren't able to do before. They're better at Pilates. They feel like they have more endurance. For some patients, improves lower back pain. Everything corrects once the body's in alignment again. And so it's tightening the abdominal musculature
Yeah.
and then removing all the excess tissue.
Do you move the belly button too? I mean, do you
That is the number one question. I'm glad you asked that.
Yeah.
So the belly button, and this is the hardest part for patients to conceptualize sometimes. So you kind of have to just see it in action, but the belly button stays connected to the body. So the belly button has a stalk, which goes down in between the rectus muscles. And so that stalk is left attached. And I make a little cut around the belly button in the beginning of the procedure. And then it kind of gets just pushed down and everything gets lifted around it. Then at the end of the procedure, when all the skin is pulled down, the excess laxity is removed and all that skin is removed, then you're able to transpose or pull out that belly button where it's already coming out, but you just make a new hole and pop it out through there.
So when you're doing all of these procedures, they have different recovery times, yeah?
Yes.
So like a breast augmentation recovery is typically how long?
So patients feel really good after about 24 to 36 hours, meaning that they're off of pain medications. They might just be taking some occasional Tylenol or Motrin. They're feeling pretty good. They feel sore like they had surgery, but they're not bedbound on narcotics. That's just not the way things are anymore. So 24, 36 hours, they're feeling pretty good. But I hold all my breast augmentation patients back from doing physical upper body workouts for the first 4 weeks. But even from the first week, they can get dressed, they can shower on their own, they can
They
prepare
can get
meals.
dressed? You mean they're not supposed to go out and just show the world their new body?
Unless they're really happy, then I'm not gonna stop them, but, that's on them. They can do all their daily activities of getting dressed, making food, showering, cleaning themselves. That's all fine from the first week, but I just don't want anything repetitive or heavy for the first 4 weeks. And that's pretty much across the board for breast surgeries.
Okay, so I'm gonna ask you a question, and I want a quick answer. The most unexpected patient request.
Elf ears.
Elf ears.
Yes.
Wow. Did you do it?
No.
Okay. All right. The most rewarding reconstruction.
I think the first time that I did a nipple-sparing direct-to-implant reconstruction. So that's a fancy way of saying that the patient didn't have to have their nipples removed, so they kept all their skin. And instead of doing it in a two-stage procedure with tissue expanders and then putting in implants, I did a type of reconstruction where you can go straight to implants with a certain type of mesh, and everything worked out great, and that was a home run.
The funniest thing someone has said post-op.
I thought you were going a different direction with this, so I already had something loaded because it came so quickly. I thought you were going to say the funniest thing a patient has said, and this was a patient. I'm going to tell you this one because that's what came to me right away. Every time I touched her breast or around her nipple, she made a honking sound.
Like meep, like
That was so hard not to laugh in the room, and she was doing it every time
this was the husband?
the patient, the woman. Every time I was examining her in the office and I would get close to the nipple area, she would make a honk sound.
Did that happen when other people were examining?
I don't know.
Okay. Most common misconception people walk in with.
The plastic surgery is this very intimidating and standoffish experience where we're gonna like hyperanalyze their body and point out all these insecurities. And it couldn't be further from the truth in our practice. I think we create such a feeling of like welcoming and warmth, and there's none of that judgment or pulling people apart and nitpicking and finding insecurities that they weren't aware about. That I think is the thing we hear back from patients, that at the end they come in nervous with this misperception about plastic surgeons and plastic surgery, and then they leave saying, wow, he was actually like a normal guy. Like, we just had a conversation, we talked about what my concern was, and we're gonna fix it. Like, and he was easy to talk to and relatable, and he's just a normal dude.
Most surprising reason for a surgery.
I had a patient who hid a tummy tuck from her husband, which is mind-boggling. How do you hide a tummy tuck? She told him that she was having a female surgery, and then she comes out with this big, like, incision. I don't know. That was kind of an interesting one, and she didn't tell him that she was having a tummy tuck. I don't know.
Most memorable family reaction.
I mean, there's definitely times when spouses have teared up, with I think the mommy makeover ones are the ones that for both, it's an emotional thing for the patient, the woman undergoing those mommy makeovers, which kind of restores that pre-baby body, but also the husband sees both. I mean,
Husband's in there like,
yeah, he's like, let's
tight.
do it, right? Without getting too graphic, I can think of one patient told me a story that she was like, after surgery, she was with she was the first time in the shower, and her husband's helping her get in the shower, and it's not a glamorous experience. Let me tell you, the first time someone gets in the shower after surgery, it's an event.
Yeah.
There's drains, there's
Oh, yeah.
things, there's dressings. It's a whole thing. The patient's kind of bent over. There could be a little bit of drainage. And she told me after the fact that her husband told her, well, he was like helping her physically get in the shower. And he stopped at a certain point and he's like, babe, I'm not going to lie, I'm a little turned on right now. And I was like, what? Like, why are you telling me this? Like, it's the first time in the shower. She's like, definitely not at her best by any means. And he's already like expressing like, this is it. Like, he's ready.
Oh, man. So recently, not even recently, really throughout probably our time, there have been like public figures or celebrities that have had plastic surgeries. Are there any ones that stand out to you other than the Kardashians and their perfect plastic surgeon that did all their faces really well?
Plastic surgery has become definitely more mainstream. I think the internet, social media, all these things have really contributed to making it a much more socially acceptable and household kind of word. And it's good because, it used to be super taboo that you wouldn't tell anyone, maybe not even your spouse, that you were having plastic surgery. And now it's like people are posting on Instagram what size implants they have and if they're above or below the muscle. I mean, that's crazy to think like how far we've come in like just, 2 decades. But I think it's good. I mean, these aren't it shouldn't be a dangerous thing. This should be a rewarding procedure for the patient, and it's an investment in themselves, and they should be proud to share that if they want to. I think a lot of that has been spearheaded by celebrities of, for whatever they're famous for, call them a celebrity.
Yeah.
But I think overall, I think it's helped normalize the field. I think where it's hurtful is when you see unrealistic expectations and you see edited or filtered images, which there's a lot of all over the place.
Can you tell when you're looking?
Yeah, I can
So you like look and
tell.
you're like, that's bullshit. Like,
Yeah,
she doesn't look like that.
yeah, yeah. You can tell pretty. 'Cause I mean, as a plastic surgeon, you know what more or less is possible and what's not.
Mhm.
And if it looks too good to be true, it probably is.
You're married. I'm married. Question. You operate on women every day of your life, right?
Yeah.
Okay. And probably men. Does it ever get in the way of your relationship with your wife? Like, is your wife ever like mad at you? Like, oh, you just saw those. Like, you just think that everybody can look like that, motherfucker. Like, does that ever does that ever happen?
She says
Or
it
is-
just like that, actually. That's what's crazy.
Yeah. They didn't have 3 kids.
So we met in college.
Okay,
So she
okay.
has been through every
Every-
step of the way from college, medical school, residency, fellowship, practice. So she's kind of seen every aspect of it. The answer is no, it doesn't bother her. She knows that, like, yes, the afters look good, but she knows that people come to see a plastic surgeon because maybe they don't look that great, but
Yeah.
at least they perceive themselves not to look so attractive to themselves or something like that. So, and her friends say the same thing to her, like, are you jealous? Your husband looks at breasts all day long. And it's like, well, no, he looks at sagging breasts mostly all day long. It becomes very clinical at a point. Like, yes, there's definitely a person there and we're treating the person as a whole. Don't get me wrong, we definitely are. But at a certain point, you turn on your surgeon brain and this becomes an operation.
Yeah.
And you, especially once the drapes go up in the operating room, this is now a technical procedure that you're going to deliver on. At least that's how I view it.
Have you ever operated on a family member?
Yes, I have.
Wow.
Yeah, I've operated on my wife
Okay.
and my mom as well, actually.
Oh wow.
And so I know that's a subject, right? So and
Wait, what was that like? Like seriously, like operating on your wife is on the table.
Yeah.
You're in your surgery center.
Yeah,
You got all these other people that are doing things for your wife.
yeah.
Are you like, all right, listen, if you don't do this shit right, like she's gonna fuck with me and I'm gonna be upset and I don't want to be fucked with. I don't want to be in a bed. Like, how did that go?
So yeah, I mean, she'd been talking about it for a long, long time, and it's kind of like the greatest like gift you can give someone. I mean, if you think about it, like that's how I view it.
I'm
Is
the greatest gift
Yeah.
I can give my wife.
like to be able to do that for someone, The way I approached it was like we're doing everything exactly the same way we do it every day.
Yeah.
No one is changing any protocols. We're not having any different anesthesiologists. We're not doing anything different with the nursing. Everything is being done exactly the same way. Because when you start making changes and exceptions and doing things a certain way for particular like quote VIP patient, that's when stuff hits the fan. It's not when you're doing the normal routine stuff. And that's in all of medicine. It's like, if you're a movie star and you go into the hospital, you want to be treated like John Doe. Like you don't want special treatment because that's when things fall through the cracks.
Correct.
That's when things happen. So yes, there is a different level of, emotions involved. But again, like maybe I'm weird like this. I have that ability to kind of just disconnect once the drapes go up and you're looking at a certain part of the body and you're focused on what your task is. Like that's the scientific doctor side of my brain that I can turn on.
One of the things, and this is a question I really want to ask you. I've never asked a plastic surgeon this question. When I say the word plastic surgery, saying the word plastic for me
Mhm.
makes it sound kind of like,
Fake.
yeah. And
Yeah.
and I wonder, has the plastic surgeon and any of these meetings that you go to, have they ever thought about changing the name of the field?
It hasn't come up in that directly. I mean, the word harkens back to the Greek word plastikos, which is something that's malleable or moldable. So that's where the origin of it came from, which is what we do. It's changing the shape and form of something. Being a board certified plastic surgeon carries a lot of clout. It's a whole different level of training and understanding.
So at the end of this, we always do like a specific, we call it a positive pulse. So it's an example of either an experience you had that was very positive with a patient or a family member or whatever. An experience where you did something and you're like, I mean, you kind of just said it with your wife. Like, I thought it was awesome. I did a great job and she loved it.
I think that was really a powerful experience. I mean, not only giving your spouse, your partner that gift of, of surgery, be able to do that for them, it's a pretty powerful gift. But then to go home with that person and recover them, that's a different experience. Because normally I do surgery and then they recover and it's like, bye. Like we'll see you in a week.
But now you get to test drive.
Now it's living through it. So that was a different experience. That was pretty powerful. So, I helped her with the initial phases of recovery, and being there and really living that process with someone is totally different than being like, okay, on day 3 to 5, you're going to experience this. Call if any questions. It was great to see it, because I learned more as a surgeon. You don't often get to live with your patient in many specialties, unless your kid has a cough or a cold and you're a pediatrician. But as a surgeon, we never get to live with our patients. We send them home or they're in the hospital and we check in on them on rounds, but that's it, right? So that was definitely a educational experience for me as well, just living and breathing the post-op course with someone.
I'm guessing it was a mommy makeover.
Yeah, of sorts.
Yeah.
Of
sorts. Yeah. Okay.
Yeah.
So yeah, it allows you to be able to talk to the individuals that come into your office that want the same thing.
Totally.
That's great. I mean, I think that's absolutely wonderful. Where can we find you, Dr. Waltzman?
I am easily found. So I am here in Long Beach in Bixby Knolls, and we're on the internet. We're on social media. The Waltzman Institute is the name of our practice, and that's our social media handle. WaltzmanPlasticSurgery.com is our website, or you can give us a call directly.
Listen, guys, you heard it from him. He has no issue with the word plastic surgeon. Loves it. Thanks a lot for watching and listening. We're on Instagram with the Health Exchange Podcast. Get us wherever you get your podcast. Find us on iHeart, Apple, YouTube, all the things, including Spotify. Thanks again. Take care.